Hello, I'm pleased to be here to present at the Rett Syndrome Europe conference, and I'm going to be trying to focus on emotional behavioral autonomic dysregulation. First of all, the conflicts of interest. I'm the head of the Center for Interventional Pediatric Psychopharmacology and Rare Diseases, and also the SIP Rett Center. I also am the CEO and shareholder in Health Tracker Limited, which is a company that helps online monitoring of patient information and health monitoring. Apart from this, I have received various research funds for clinical trials from different companies and also from other research organizations like the EU FP7 program, NIHR, Action Medical Research, and so on. The SIP Rett Center is part funded by Reverse Rett, a charity, parent charity in the UK. Coming to how the center has been set up, the SIP Rett Center has got a clinical arm as well as an academic arm. The clinical service sits within the Maudsley Hospital, and the academic arm is within King's College London, and we also have links with King's College Hospital, especially with respect to the clinical trials facility, because we use their trials facility. Apart from this, we've also got links with Great Ormond Street Children's Hospital, Tadworth Children's Trust, and we also have direct links with Reverse Rett and also Health Tracker Limited, which helps us manage patients remotely using the online platform. What does the Center for Interventional Pediatric Psychopharmacology and Rare Diseases do? We see very many rare diseases and complex neurodisability. SIP Rett Center is one of the largest cohorts of patients that we see, and it's a center, I think, is probably the only center in the world where we have every working day the center is functional, and we're seeing patients and managing them throughout the year. We also have large cohorts with septoptic dysplasia, childhood dementias, and so on. We also deal with patients with autonomic dysregulation, specifically with POTS or postural tachycardia syndrome, and also patients with acquired brain injury, and patients who have complications such as long QTC and who require treatment in psychiatry. And so we bridge the gap between physical and mental health. And we have a team of experts who actually deal with patients when there are complications with respect to physical health whilst treating their mental health issues. Whilst doing this, we recognize that autonomic dysregulation appears to be central to treatment resistance across different conditions. And so we've had a research focus on emotional behavioral autonomic dysregulation, and we have been involved in quite a lot of translational informatics, clinical trials, and also across rare disease identification of autonomic dysregulation and management. So, how does the SIP Rett Center function? We take a personalized medicine approach in the SIP Rett Center. We use digital phenotyping and digital therapeutic approaches using the Health Tracker platform, as well as wearable devices, which allows us to capture information such as electrodermal activity, heart rate variability, temperature changes across time, and activity levels across time. So what happens is that when a patient is referred to us, we clarify the diagnosis, we profile their symptoms, we do a structured medication review that allows us to actually understand whether there are any drug-drug interactions and manage them appropriately. And we also look at autonomic function as such. So the way it works is that when a patient starts in the clinic, we get the wearable data collected. We get pharmacogenomics from the patient. We get multi-system profile of symptoms obtained from the patient, and also questionnaires which are Rett specific. And we look at automated triaging, and using artificial intelligence algorithms, we are able to set up clinical alerts, which then help us to be able to optimize care and provide input as and when needed from the patients. So the cause of Rett syndrome is well known. This is just a slide that I've adapted slightly, where what I wanted to highlight is that the majority of patients, that's roughly around 180 patients in our center, the majority of them are being treated for epilepsy, dystonia, gastroesophageal reflux disorder, disease, or spasticity, and autonomic function and anxiety. Those seem to be the thing, and this is no different from anywhere else in the world. Now, what we first decided is that we would develop a questionnaire very specifically for rare diseases, which cuts across different systems. So we developed the multi-system profile of symptom scale, which is basically a questionnaire that allows us to measure symptoms across all the various areas that are affected in different rare diseases where the brain is involved. So this scale was developed using the FDA protocol for developing PROMs, and also what it allowed us was that we standardized it in a manner that each module could be used in its own right. So therefore, this has now been published. It's now being used in different conditions, and we believe that this is a good questionnaire to be used alongside other measures in order to be able to monitor treatment across time. So this would be an example of a patient who comes in with the profile. So we look at the profile, and then we can actually have a look at what's happening across time when the patient is being treated with any repurposed molecule. For example, buspirone for managing respiratory problems, or using propranolol for managing tachycardia. So the structured medication review, which I discussed, the health tracker has got a module which allows us to go into each symptom by symptom, look at all the treatments that have been used, what side effects occurred, and then the algorithm at the back end provides us with a mechanism to be able to look at all of the information in a single screen that allows us to help manage the patients better. This definitely reduces drug-drug interactions, and also it assists families to be able to present information in an appropriate manner, because we help them to repackage medical information in an appropriate manner to help them present to the different specialists they're going to be seeing. So now, coming to the emotional behavioral autonomic dysregulation, I have a few slides for that. First of all, what we did was that we first established what would be considered as EBAD in Rett syndrome. So, for example, behavioral dysregulation would include the repetitive rocking, the screaming, self-injury, stereotypies, scratching, agitation, sleep, that sort of behaviors. The emotional dysregulation is to do with anxiety-based and mood lability. And of course, the autonomic symptoms are with respect to breathing difficulties, temperature abnormalities, vasodilatation, vasoconstriction, and so on and so forth. So what we did was that we first wanted to check and see whether our markers, biomarkers, physiological biomarkers from the wearable devices was able to differentiate between Rett syndrome and girls with ASD, with similar, who were case matched. And what is very clear is that the artificial intelligence algorithm that we developed could almost map them out to more than 95% accuracy. So this was the first step for us to feel comfortable and confident in terms of the physiological biomarkers for autonomic function within the context of Rett syndrome and ASD. So subsequent to that, what we did was we wanted to understand autonomic dysregulation in the context of acquired brain injury, because we also see patients with acquired brain injury where autonomic storms are very common. So therefore, what we did was we did a systematic review, looked at all of the functions that had been identified in acquired brain injury, and recognized that there were quite a lot of commonalities. So, for example, anatomical regions that were considered to be relevant in acquired brain injury were the thalamus, the hypothalamus, and so on, and the networks to do with the brainstem. So what we did was that we also then looked at how autonomic function could be measured in the autonomic dysregulated group. We standardized the procedures, and we looked at all of the standard treatments that were being used in acquired brain injury, such as clonidine, propranolol, guanfacine, and so on, which then would help us to look at what is the evidence base within the context of Rett syndrome, and then make appropriate treatment recommendations. Similarly, we then went one step further to look at what are the different aspects that are involved in sudden death in Rett syndrome. We did a full systematic review, and what became very clear is that when there was respiratory medications that caused respiratory depression in the context of sepsis or seizures, and medications that produced long QT, were all high risk factors, because all of these led to autonomic instability and long QT, which then could lead to cardiorespiratory dysfunction and sudden death. So what we have proposed is neuroprotection, similarly cardioprotection in the context of high risk factors when there is long QT, how to manage it, and so on. So this is something that is routinely screened for in the clinic, and we then link up with the appropriate specialists and manage to try and provide cardioprotection in the high-risk group. We then went one step further to look at how the wearable sensors could be looking at the heart rate variability in Rett syndrome, because they are different in when they're asleep versus when they're awake. So we developed measures, and for the first time, we developed norms where from all of the literature put together, we proposed norms that could be used to be able to look at whether a particular patient's indices were within the norm or expected norm or not. This, I think, has huge implications, because if we can shift patients who are outside the norm into the norm with treatment, this allows us to be more certain about the impact of the medication on the treatment. So after that, what we've done is we've looked at impact on various medicines on autonomic dysregulation in children, including in autistic children. So we've published on propranolol and how it can be used to manage autonomic dysregulation in ASD. And we've also published about how the autonomic dysregulation can actually be a key target for clinical trials, especially for the new oncoming trials, such as gene therapy. So this is just an example of a case with a patient with autonomic dysregulation. The first thing right on top is to do with the motor movements in purple. And then you've got where in terms of the z-axis, in terms of movement, what's happening in the z-axis of the accelerometer. And then we've got the electrodermal activity measure after that, and then we've got the heart rate, which we have corrected separately using a separate algorithm, because we wanted to make sure that the data that is being collected is actual true data as opposed to imputed data. And what this shows is that our algorithm picks up periods of autonomic dysregulation, which clearly requires treatment. Again, this is something that is being done for all our patients. This allows us to monitor what's happening across time. This is another patient where you can see that there are again autonomic dysregulated episodes, and what you can see is that in the purple on the top, you can see quite a lot of stereotypic movements as well being captured. But what is interesting is that the autonomic dysregulation is not associated with the stereotypic movements, but it's occurring when it is actually they're at rest. So this is and this particular patient also had quite significant increase in heart rate. And so therefore, we have been looking at managing these patients using specific strategies. This is just to give you another indicator of objective measures for sleep in these individuals. So we can actually measure where in this particular individual there is disturbed sleep, and we have all the sleep indices, which we can then look at post-treatment, whether they are improving or not. This is a very specific thing which we have published before, which is about a case where we had used buspirone to manage the autonomic dysregulation. And what you can see is that in blue is the electrodermal activity on the top and the heart rate below. In blue was what the heart rate and the electrodermal activity was before starting buspirone. And in red is post buspirone. And what you can see is that there's a significant reduction in the autonomic biomarkers, which suggesting that apart from the symptoms being better clinically, there was also physiological normal improvement when treated with buspirone. The model for the Rett Center is to use augmented health, digital health strategies to be able to improve both clinical and research outcomes in this group. So the first thing is that whenever a patient comes in, we get the data. We use the data, especially in terms of the multi-system profiling questionnaire. We use it to be able to automate or for automated triaging. And based on the symptom profile, we are able to actually match the patient and the clinician in the center so that we can actually get the best for the patient. We then collect all the other assessments which are there, and this is an ongoing longitudinal database that we have. And then what we do is that we can also get observation measures whilst they're using the wearable, so that we can actually pinpoint when some particular biomarker may be linked to, say, for example, epilepsy or dystonia. Apart from that, we then have automated risk alerts, which when the family completes a questionnaire, based on data we already have, it alerts the clinician to say that this patient's data appears to be abnormal. Do you want to do something about it? So we can then contact the family and then manage the patient proactively. The structured medication review helps reduce risk. And what happens is that we can then data mine the whole data set at regular intervals to help improve quality of care, because we may gain insights. So, for example, more recently, we've picked up that molecules such as buspirone seems to have an impact in terms of autonomic function and breathing, which then has helped us submit for publication, as well as plan for managing these patients more comprehensively. So in conclusion, what we can say is that care should be patient-centered. We have to provide shared decision-making. It is multidisciplinary and multi-specialty. Structured medication reviews are important. If we use online health monitoring, we can set up physical and mental health alerts, which can then allow for better patient care. We've specifically looked at autonomic markers and recognized that there are methodological issues with respect to imputed data and stitching of data for analysis. This is more of a research topic. However, our team has been focusing, our data scientists have been focusing on managing this particular issue so that we can get more appropriate outcomes in terms of understanding what these digital biomarkers mean. We are also working at the same time to look at digital biomarkers for stereotypies, dystonia, gastroesophageal reflux, and so on. We feel that it's the right time for autonomic dysregulation to be considered an objective endpoint for clinical trials, because one can actually measure it quite well. With this, I come to the end of the presentation, and I'm more than happy to take questions. Thank you.